Now we'll move on to our next session, joint replacement and its rehabilitation considerations. For this session, I'd like to invite on stage the chairperson, Professor Dr. Utpal Bandyopadhyay, sir, Professor of Orthopedic Surgery, North Bengal Medical College and Hospital, sir, and Dr. Shankar Prasad Sinha, sir, Head of the Department of Physical Medicine and Rehabilitation, Peerless Hospital. I'd like to call upon stage the first speaker in this session, Dr. Soumya Chakraborty, Consultant Orthopedic Surgeon, Fortis Hospital.
Good afternoon, everyone. I'm Dr. Soumya Chakraborty, Consultant Orthopedic Surgeon in Fortis Hospital. So today I'm going to discuss about the robotic total knee replacement because there is a lot of buzz going on regarding this topic. So why this robotic thing came in? So we are, like most of our patients were very happy about the conventional knee replacement outcomes. So why this robotic thing actually did come up in the market? So we still see that around 15 to 20% of our patients are unhappy after the joint replacement surgery. So that is why we want to address the unhappy patients. Lot of talks about alignment, about implants, and mostly the navigation and the robotic thing has come in after that. So we want to address those unhappy patients and we want to see where the problem lies. So first I'll just show you a few slides regarding the joint replacement surgery with Velis robotic system. So this is basically by the Johnson & Johnson MedTech company. So I've used robotic systems in the past also of two other companies, but I found it very useful and very good to use. So first I'll just show you a few slides regarding this joint replacement system. After that I'll take you through a video because post-lunch session is will make you a little drowsy, so probably a small video will help us out. So this is the Velis robotic system. This is accurate, precise and reproducible. This can be adopted by most of the surgeons. Even a very senior surgeon of my hospital has adopted to it. And this is a surgeon control device. This is not an autonomous robotic system. The cutting device is held in our hands, and no CT scan or any imaging is needed in this robotic system. And you don't need any technician, any additional company person to use this robotic system. And this is a compact size. The size is compact. You can just take it from one operation theater to another. And this is a very low maintenance system. This actually doesn't add to the cost much. Okay, so this is a FDA approved system. This was launched in July 21 in United States. And it was launched in India in November 22. And there has been around 100 installations so far in the country. So this is the fastest growing robotic systems used in our country. So this is little technical. We have got all these things. We have got a monitor. We have got another monitor which is actually bed mounted, which stays with our operating table. And this is a device which is actually the cutting device. So this and this is actually the best station. So all these calculations and everything goes on there. And there's a saw handpiece. You can just see it from here. There's the instrument trolley there. The array sets are there. So yeah. So this is just the best station and satellite station and the device and the holding arm pictures. So from here the technicalities start, but I'll just take you through the video so that you can just understand better what we do like differently in this robotic system. Yeah, so this is the Velis robotic system. This is, yeah, so this is how the screen shows. So this is the actual camera, and this is the calibration of the saw. So this is how the system sees it. I'm Dr. Soumya Chakraborty from Fortis Hospital. So this is the X-ray of a 72-year-old lady. So we can see from here. So some surgery underwent in her contralateral limb, long back. So it was kind of a epiphysiodesis. So it was a short limb. You can see from the gut of the tibia also. So it's a shortened right lower limb. So the patient used to work almost on the left lower limb for many years. Right now she is having stage 4 osteoarthritis in the left knee, and you can see all the osteophytes from here. So we just have a look at the patient, how much is the varus. Okay, so here you can see from here the patient is almost 20 to 25 degree of varus here. So I am just performing a full range of motion. The range of motion is good, so there is no much flexion deformity from here. The flexion is possible up to 110 degrees. So we are taking out the meniscus, the medial meniscus, a little bit of anteromedial soft tissue release. So we are now putting the pins inside the tibia. So 2 pins will be put in the tibia and 2 in the femur, and there will be optical trackers in the pins. So I'm just putting the tibial checkpoint. Yeah, this is a tibial checkpoint which is necessary in this system, just to see that everything is in place or not, because so this is a tibial array which is placed here with the pins. Yeah, so the tibial as well as femoral arrays are placed. Now there will be the saw calibration. So the system will move the saw a bit, and it will see whether so it will move to its home position again. Now my profile has been selected. Yeah, so this is my profile, how I so this circle has to be in the center, so that the knee is visible in flexion as well as extension. So this circle has to sit inside the designated area. So the camera adjustment is done. So now I'll just check whether the knee is visible in flexion as well as extension. So this step is important, otherwise we won't be able to see it in a later stage. So I'll go to the checkpoint. So this is the tibial checkpoint, and I'll take the femoral checkpoint in the array. So now we'll register the center of rotation of hip. So this is to establish the mechanical axis. So as I rotate the hip, the system will automatically take the center of rotation of hip. This is to establish the center of ankle. Yeah, so this is the medial as well as lateral malleolus. So this is the tibial center, just behind the footprint of ACL. So this system is all about the registration. As I show it to the system will register the important points. As there is no preoperative imaging, so it all depends on the registration. So this is very important. So this is the center of lateral tibial plateau. So this is the tibial sagittal axis. So this is the femur knee center, just 1 millimeter medial and anterior to the PCL insertion. So this is the white side line. So now I will acquire the medial distal femur. Medial distal femur. I just need to paint it with the probe. So I'm just painting it. The system will automatically take the most prominent point. So the thing is same over the lateral femoral condyle. So now I will register the medial posterior condyle and the lateral posterior condyle. So I'll just paint it, and the system will take the most obvious point. Now I'll now draw anterior line over the straight line over the anterior cortex. Yeah. So now this is checking whether every point is in proper place or not. Yeah, so if it's within 0.4 millimeter, so it will come as green, otherwise it will come as red, and again I have to re-register. Yeah. So most of our points are green at this point of time. The anterior cortex is important in sizing. Yeah, so I'll just take the knee through a full range of motion. So in a varus knee, I'll just put some valgus trace so that I'll know how much varus is correctable. So these are the gaps which is shown in extension, as you see 2 mm and 9.5 mm. The same thing will be seen in 90-degree flexion as well. Yeah. So this medial and lateral flexion and extension gaps are shown in the picture. So now here comes a screen, and we can plan our tibia cut first. So here is the screen. How much varus valgus to give? So it's in 0. I'm putting 2 degree of varus to it. So the right hand side is how much to cut from the medial and lateral tibial plateau, and the so this is how much to cut from medial and lateral plateau. I can adjust it, and the gap will adjust accordingly. And the right handmost side is about the slope, the tibial slope. And the upper screen is all about the femur. I'm not addressing that right now. So here is the checkpoint. Now I'll proceed with the tibial cut. So here is my handle device. So according to the plan, it will cut. So here no instrumentation is required. So as we planned, we'll just go for the tibial cut, and it will cut only in the same plane. So my tibial wedge will come out. Okay. So I'll just cut the root of meniscus, and so at this point I'm supposed to cut the whole medial as well as lateral meniscus, whatever is left, because it will affect my gap. So it's better to size the extension. Yeah. So this is a sensory tensioner device. This will actually measure the soft tissue tension. So this is not only about the bone cuts, it will measure the soft tissue tension. So with the sensory tensioner device in situ, I'll just take the knee through another range of motion. So, because this will determine my final gaps. So this is how the gap looks like in extension and in 90-degree flexion. So now there will be my final planning. So here the difference is in the robotic system. So we can adjust the varus valgus, we can adjust the rotation, we can adjust the anteriorization or the flexion or extension of the component. So this thing will help us adjusting everything in millimeter as well as in angle. So I can change it to 0.5 millimeter or 0.5 degree angle. Everything can be changed here to get the right measurement. So I'm just putting 0.5 degree more varus to the femur. So the HK comes out to be 3 degree. So I'm adjusting the rotation to adjust the flexion gap in medial and the lateral space. So I generally want it to be 11 and 13 here. I'll just take 1-2 minutes more. So with all these adjustments, so I'm just cross checking whether now the device is again coming into play. So according to the plan, it will proceed. So proceeding with the distal femoral cut. So I'll cut the anterior femoral cortex here. It's important to avoid notching. Yeah, so this is the anterior chamfer. I'll just quickly proceed through it. Yeah, this is the posterior chamfer. At the end, I'll cut the posterior femur. So I can only cut in the previously planned plane. Otherwise, the saw will only cut at the same plane. Yeah, so I'm just taking out the bone from the posterior femur, as well as I'll just take out the osteophytes, any osteophytes if left. Yeah. 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 Now I'll just put the tibial tray as well as the poly, the trial poly, and now I'll put the femoral implant. Yeah. Now here at this point I can check the gaps. Yeah. So at this point I'll check my gaps. Okay. So it has to be within 1 millimeter or 2 millimeter in flexion as well as extension. Yeah. So at this point, if I feel something is wrong, I can just change my plan and come back. So here there was a little bit of flexion deformity left, so I'm just releasing my PCL a bit. So there is a little bit of PCL release from the femur. Yeah. So it's now about the tibial preparation and the implantation. I think I think we have just put it. I'll just close the screen now. Yeah. Thank you. Thank you.
Thank you, Soumya. A nice deliberation and excellent video presentation.
You're welcome.
It's becoming clearer to all of us.
Yeah.
Just one thing is coming. Any question from the audience? Achha. Anyway, just one thing, just
Absolutely.
to clear us. How much extra time does it need for registration and other things?
Sir, for this particular robotic system, I need 10 minutes more. Because I finish my conventional knees in 35 to 40 minutes. It takes around 50 to 55 minutes. This is the beauty of this system, because you don't need much time for registration. This is all just painting. And this is a very smart system, and it's like no other registration is needed. And the best part is this is basically motion insensitive. Like you flex or extend the knee and the camera will adjust accordingly. And your saw and everything will adjust accordingly. So it actually takes 10 to 15 minutes more.
Okay. Thank you.
Thank you.